portion of the presentation.
All right. Thank you. Thank you, Kapil. So before I start, I would like to thank and congratulate first Kapil and his team for taking this initiative. I mean, we are in a very difficult time. We all know due to the COVID-19. It's a very difficult time for schools, for hospitals, for our economy, but still, this really proves the determination of all of you. If you really try, given the technology and given the services that we have, we can still continue the medical or any form of education. We can still continue it. So this is really a very commendable work. And again, I would like to thank you, Kapil and team, and all of the the people who are in this meeting or this conference. So without further ado, I'd just like to start my topic. So the topic of presentation today is ocular emergencies in brief, where I'll be discussing about the various ocular emergencies and also their primary management. Now, why, Kapil and me, before we started this, we had a talk regarding what should be our topic, and we actually went through various other topics that actually we came to an end about talking on ocular emergencies. This is especially very important because right now, if you take the scenario right now, due to the factor, the COVID-19 and all the calls that the ophthalmic assistants or optometrists or even us ophthalmologists, all we get the calls is basically, okay, you'll be only attending the ocular emergencies. Ocular emergency is the only the cases that will receive the priority treatment, and those will be the first cases that we will all be attending. So to understand, in the whole concept of what is an ocular emergency, what you should consider an ocular emergency, first you have to know what are the ocular emergencies, because without knowing an ocular emergency, it doesn't make sense, because people who's sitting in the emergency or somebody on the phone might be saying, oh, I mean, calling and telling you, hey doctor, we've got an ocular emergency, you need to come. But at this time, when there is no proper vehicles, and when I think you have been following news where even the doctors are getting beaten up in the streets because they were attending the emergencies, you really have to know what are the ocular emergencies, because a person who is coming to an emergency room and just saying, I am having burning sensation in my eye, or I am having dryness in both my eyes since maybe 1 year, and just because their medication was lost, or they stopped the medication from 7 days, and now they're having the same burning sensation. I mean, it makes no sense for all the human resource and for us to travel to the hospital and just attend that case, because it's not an emergency. So to avoid all of those things, and actually such cases which can easily be managed by a simple telephone call, or we have various social networkings, we can just manage such cases. And so to filter out what are those non-emergency case and the actual or the true ocular emergencies, we have put up this presentation today. So as we move forward, if you have any queries, please, I would like you to note it down in your paper or anything, and in the end, I would be happy to answer all of your questions. So to begin, we're starting with ocular emergencies in brief. So to begin, what I would like to say is, because when the question came that all the eye care providers, I would say that all of us are eye care providers at this moment. So we really had a difficulty saying what are the ocular emergencies. So there are various academies and various institutes. They came up with a list saying, okay, this is the ocular emergency, and if you start following all the ocular emergencies that are enlisted, then I mean, we can simply restart everything, because like the list of the ocular emergencies, they keep on going and going. It's like around 200 or 300 emergencies. I mean, the list that includes, you know, of the ocular emergencies. So it's really important that we filter out, because for example, if I am being called by someone saying, okay, someone has a trauma, then there is a retinal detachment, right? So it's an ocular emergency. But if I just run to the hospital unplanned, and I go there, check the patient, okay, the diagnosis was correct, the patient has retinal detachment, then what do I do next? What do I do next? Because I don't have a person who will you know, do all the investigations. The laboratory is closed because they're only looking at very specific patients. Okay, if I say I want to take the patient into the OT, I don't have a person who gives the block or does all the pre-op checks. I don't have a person in the biometry. And if I plan to operate, I don't have the person, you know, getting all my systems ready, or even I don't have an assistant. So, you know, even if it's an emergency, how rapidly should I address, and is it feasible for me to address that kind of retinal, the ocular emergency right at the moment? Is it feasible or not? And in such scenarios, what should we do? These are the things which we must consider. So to avoid all of those things, even if you get a call, or if you're called for an ocular emergency, there are certain, you know, specific questions or specific history, you know, questions which can be asked to the patient or the person who's calling you, to actually know about whether the, you know, is it a true emergency or not. So first thing is, you know, vision is the most important thing, because we are related with eye. We won't say, you know, like, I mean, for example, a person who has a trauma to the eye, it's useless asking him, can you hear properly, or, you know, like, are you having other difficulties? Because we are eye specialists, we deal with vision. The patient has come to us with problem of vision. So if we ask them, do you have any problem with the vision? And we ask them if they are, you know, regular readers or doing their work. We ask them, do you have any problem doing your regular work? Are you able to read the newspaper like you used to before you started having the problem? Are you able to see what's on the television properly before you started having the problem? Are you able to carry out your regular duties if you're still having the problem? So that will basically, you know, like, give you the overall view of the disease. For example, a person who has a trauma might tell you, yeah, I'm just having a little bit of a pain, but I can see it clearly. Maybe that's not a very you know, it's not an emergency that is you need to attend immediately. But someone who's just one-eyed, the other eye is not working, and just one-eyed calls you and says that, you know, doctor, like, I woke up today and everything is dark. I can't even see my hands moving. All I can see is you know, some light flashing. That means, you know, that's a kind of a true emergency, because the patient is one-eyed. The second is it's a sudden onset, and the person even can't see their own hands. So that also defines what an emergency is. So if that kind of a history is there, then you have to again confirm what was the cause, because the cause you have to find out, you know, like, for example, a young patient who is sleeping who had a completely good vision until yesterday, was watching television, and he slept early in the morning, he has loss of vision in both eyes, or in a single eye. That is more concerning, you know. So you have to rule out from the history itself, saying if that person had similar history in the past, or any condition for which he had received ocular treatment, or was that patient myopic, or was there any history of retinal detachment, or, you know, history of retinal surgeries, or not even just that, you know, like it could be just non-retinal detachment, but a myopic who had received laser treatment to the eye maybe 6 or 7 months back, or maybe just few days back or a few weeks back in your hospital, when your hospital was still functioning. The other thing is the family history of glaucoma, and strabismus, you know, especially this is very, very important, but not, and I'm just going an overall for the ophthalmic history, but Why is it important, will come later on. I'll tell you about why this family history of glaucoma, squint, or strabismus is important. Then there is a special questions that we need to ask ourselves, like the patient won't tell us, because sometimes these include a very specific questions, and we're trying to move from the complaints to our diagnosis. For example, we have to ask the patient, like for example, diminution of vision, when did it occur? And the person says it's been like around 2 days, and there was a history of foreign body entry. Now discharge is starting from yesterday. The pain is very severe, maybe a corneal ulcer. Pain is not very severe, only occurs during blinking, maybe a foreign body in the eyelid, or there is no pain, just discharge. Maybe it's just a simple conjunctivitis, or like it was hit so bad, the pain was so much, the patient is not able to sleep sleep at night, and today morning the whole eye is red, and there's something pus or warm fluids coming out from the eye. So it could be a trauma due to a foreign body which has entered the eye. The patient now has endophthalmitis. So these are some of the things you can ask the patient specifically to know about whether it's a real ocular emergency or not. Now there are other various things, like for example the medical history of diabetes or vitreous hemorrhage, because what happens is you might be called for a sudden diminution of vision in a patient which is an ocular, in which you might consider it to be an ocular emergency. You rush to the ER, you dilate the patient, and you see this fundus, right? Then this fundus will make you think that the person has a vitreous hemorrhage. Now that's a problem. It is a kind of ocular emergency. But if you don't ask the history of diabetes, the person could be having the diabetes for like 2 or 3 years, and he could be having a proliferative or a non-proliferative diabetic retinopathy, for which you had asked the patient to follow up. Because like you had already seen the patient before, and you knew that this person would develop a vitreous hemorrhage or some kind of a sight-threatening damage to the eye, but due to the lockdown or something, the patient was not able to attend. Then you are, like you already know a basic of the patient. You know that, okay, this person had a diabetic retinopathy. I had asked him to come for a laser, but due to the lockdown, I was not able to provide him. So it's probably just a vitreous hemorrhage, not related to other dangerous thing, but it's just a diabetic retinopathy. So, and it's not very severe. So what I can do is maybe I can just ask him to, apply some, ask him to apply some topical drops and ask him to rest with a head elevation, and maybe just go and check for his sugar and blood sugar or blood glucose, and maybe consult another consultant before. As I was saying, a complete dilatation and looking at the retina is very, very important as well, and also to assure the patient that although this is an emergency, it need not be operated or addressed immediately. The diabetes was there for a long time. We had already told the patient that the patient would need surgery or a laser or an injection sooner or later. So the patient can wait for now, and advise him to, while sleeping, just lift up the head a little bit, and maybe go and consult with a general physician to get his blood glucose corrected, and maybe to adjust his medications. So in an overview, the main thing is you have to identify the presenting problem. So the presenting problem, you have to be very, very careful, because like the patient, they tend to only tell the complaints that they, first they might come saying, I have an ocular pain. Then once you address them, they can deviate their problems to other things. Then they might start saying, I'm having headache, vomiting, and I starting having stomach ache, all of those things. So you have to actually identify what was the problem. So why is that important is you have to because like if a person starts saying, sir, I have a red eye and I have a discharge and I do not have an ocular pain, and it started from yesterday, and there is a history of similar thing in my child, so we'll just think maybe it's just a simple conjunctivitis. But in another thing, if we just continue with the history taking, and the person starts asking, there was a history of trauma 7 days back, then again he had washed his eye with some dirty water, then then somebody had, like while working in the garden, something had hit his head. So what happens is you start get deviating, and the problem for which the patient actually came to the hospital, we start forgetting that, and we start addressing the other problems which are not very important. So that is very important. And there are many things that might reoccur. So, there is always something which could happen again and again. For example, if I tell you a person with an acute angle closure, that person could have come around 4 or 5 months back or just few weeks back with similar complaint. Fine. And a person who is already on a medication and who is already diagnosed with corneal ulcer and has under treatment is worsening. So that person had already come to your center when it was open around 10 days back, and the patient is worsening. Fine. So those are the things which can help you find out, because like a person who has a severe pain in the eye with discharge, with whitish discoloration of the cornea, and if that person has already been diagnosed as a corneal ulcer, when the OPD and all the facilities, the lab facilities where corneal scraping was done already, KOH and gram staining was done, you already know what the culture product is, you already know what the organism is. So there is no time, there is no point wasting your time trying to get to a diagnosis when you already know the diagnosis. Fine. So that is one of the main things in the ocular history. Then the another thing is the family ocular history, where the main thing is for example, when you have conjunctivitis, or when there's a family history of acute angle closure as well. So in those cases, you might start having this is where the family ocular history could be important. A person who has a sudden diminution of vision and who is myopic, looks myopic, he has been wearing -6 or -7 or -12, and you ask him, does your family have any similar problems? Then he might say his brother or his sister had high myopia and he was diagnosed with retinal detachment and had surgery 4 years back. So that also gives you an overall clue of what the problem the patient that is coming to you might be having, given the family history. And overall, the general health, it's very important, because like some people, they use dirty water to clean their eyes, and they and all of those mainly the infectious causes or the ulcers, it can come from there. So the major problem right now is that the patient who comes to you might not have the have the same communicating skills as you have, because the language you speak could be different. Even if you're speaking the same language, the dialect, because we have, our culture is very diverse, so the same words at different districts or different provinces, it is mentioned using different words, so that could be difficult, so that is like in those cases where you cannot actually say what it definitely is. Never guess and write. Never guess, because the patient in their language might be saying, I have a discharge, and you think that word is something like bleeding. Now there's a big difference, and you write in your history, the patient complains history of bleeding. So the patient was actually saying discharge. So these are completely two different things, because this patient, after you evaluate and send that patient home today, that patient is going to come back again for a follow-up. And at a follow-up, and if the patient was saying discharge and you have written bleeding, and it's a different person who is going to see the patient, then the whole diagnosis is completely wrong. So that also needs to be highlighted, because that will determine if the case was really an emergency or not an emergency. So we already talk about the examination part. So you have to always look for the clues, like to see if it's a really an ocular emergency or not. And sometimes if the patient has one good eye only and presents with symptoms in the good eye, it's always you might be expert in your fields, but it's always good to have a second opinion. It is not real, it does not really mean that you have to consult an ophthalmologist. You can always consult your seniors or people, and who's senior to you or who has more experience to you. And there are various examinations, for example, which might help you diagnose. For example, a simple fluorescent strip can mark a corneal abrasion or a corneal ulcer, which could be, be hidden due to the upper lid, and by just looking at examination or torus examination, this could have simply missed. And sometimes you get the true ocular emergencies, that are the ocular trauma, the open globe injuries, where the globe is open and the aqueous is leaking, the lens is trying to come out, the iris is trying to come out, the vitreous, everything is trying to come out. So usually have those cases as well. Those are the actual ocular emergencies. And sometimes they also give you a history of, a foreign body inside the eye. So you also have to rule out, is the foreign body simply limited to the anterior segment, or has it gone into the vitreous, or has it already punctured or gone through and through from the in the posterior to the injuring the retina, choroid, and the sclera. So usually to find those out, you usually do a B scan, but in such cases you don't do a B scan because you have to apply pressure. And when you are applying pressure, even if people say apply a gentle pressure, that's very risky because you do not know and how big the injury is, how big the size of the injury is, So it might look small, but below the conjunctiva and below the muscle insertions, it can extend right at the back, and even a little bit of a pressure can extrude everything inside of the eye. And sometimes you send for an x-ray. The x-ray is usually good, but never send for an MRI, because if that particle is inside the eye is an iron or it's a ferromagnetic element, that means it reacts to a magnetic field, and you put that patient for an MRI, that thing inside the eye is going to do a lot of damage. It will not only just do a lot of damage due to the the magnetic resonance, that that particle can get really heated up, and it can even enter the brain or just come out from the from the skull itself. So never send the patient for an MRI. It's very important. Number one, never do B scan with a pressing if there is any evidence of an open globe injury and you do not know the extension. And second is, if you do not know what the foreign body could be, never do an MRI. So these are the very, very important things that you must understand. So the other thing, to prevent the confusion, is that record the primary reason for visit always. Like when a person tells you, why are you here, you have to always write it down as a chief complaint, and what is the problem, what is the presenting problem, and what has prompted the visit. Because what happens, as you write down, as you ask the patient and get more history, the history might deviate to various different directions, and you will get carried away. You will get carried away with your history, and you will not focus on what needs to be focused. So, has that something new happened just now, or was it occurring from some time before? This is a very special thing. I mean, this is a very, very common thing, like usually you get a call at 2 a.m. in the morning saying a patient is having pain in the eye, and you go and visit the patient, and the patient tells you the pain in the eye was occurring from the after lunch at 1 p.m. Then you start thinking, from 1 p.m. till 2 a.m. in the morning, what was the patient doing, and why is the patient worried now? That's the main question. If it was happening since the afternoon, why is the patient worried now at the middle of the night for getting an eye examination? But this does not mean that we should get angry with the patient, because the pain could be getting worse. The patient in the afternoon might have already visited a hospital or any other clinics, and may already have started getting medication, and maybe was improving a little bit. Then suddenly the pain started getting worse, disturbing the sleep. So this could be the other reasons of why the patient could be worried and presented at night. So that is another very, very important clue, because if the pain is getting more intense in the eye, it means there is more damage occurring, and which could actually mean that it's an actual emergency. So, and this is a very, very important thing, that some patient may include new symptoms. So you really, really have to find out if what the patient are telling you, is it the main thing that needs to be focused, or are there any are there fabrications, like because sometimes the patient wants the doctor to prescribe something for them. They do not believe their clinician or the person checking their eyes as long as some drugs are prescribed. So until and unless that drug is prescribed, they keep on adding more and more symptoms. So like until they get a medication, and that's when they get satisfied. So that needs to be addressed as well. So the next slide is it's the same thing that we have decided. So based on all of these things that we have asked, we have to categorize the patient into 4 parts. So over here you can see basically to see the severity and how fast you need to see the patient. Do you need to see the patient immediately? If you don't see the patient within 10 minutes, they can become permanently blind, or can that patient be waited for like around 2 hours? Especially you don't want to keep your patient waited 2 hours. It's unethical. But like the ocular emergency, we're not just talking about the ocular emergencies during this period, during the time where there's lockdown, because ocular emergencies start coming when there are various other disasters as well. For example, the earthquake that we had. When we had the earthquake, we had like around 30 to 40 ocular open globe injuries and ocular emergencies that came at the same time, right? Everyone is an ocular emergency, but at that time what we have to do is there is an open globe injury, there is another person with a iron foreign body on the cornea, another patient with a conjunctivitis, another person who has just simple conjunctivitis. So you have to categorize those patients, and say in such cases, if you have 30 patients coming to you at the same time, then you have to categorize those patients, saying who is urgent and who needs who is urgent and important and needs an immediate response, who is important but not very urgent, it is urgent but not very important, and not important and not urgent. So let me give you an example. Urgent and important are those kind of patients. For example, let's say one eye is already lost due to we do not know what happened, like that eye was lost maybe 10 or 12 years back. Now due to a trauma, that eye, the patient comes with he's a carpenter, and he comes with a nail that is inside the cornea, that has pierced the cornea and is touching the lens. So that's one case. The other case might be, so that's case number 1. Then you have the another case who has who was driving or doing something, and then suddenly a foreign body came into contact and it's stuck in his cornea. Yes, it is very important, but compared to this case, who is one-eyed and has a pin inside his eye, it's not that urgent, right? Now there can be another thing which is urgent but not important. So urgent but not important is, for example, a person who has a trauma to the eye. The eye is completely lost, it's ruptured, everything, retina, vitreous, everything has come out, right? So it's an urgent thing, but it's not very important that you give your time right there, because like that eye, even if you give importance and do an immediate repair or take him to surgery, that person has already lost the eye, and that eye is not going to see. So compared to this, still the patient with one eye who has a nail, traumatic nail in the eye, is the most important part. Then there are some people who are not important and not urgent. In case of a conjunctivitis, for example, a conjunctivitis, a patient who has come to you says there's a history of conjunctivitis in the family since 14 days. The patient had come 5 days back. Already the patient is under antibiotic. The redness is decreasing but still persisting. Discharge is there but not as much. So yes, they have come for medical treatment, but compared to all of these four patients, that patient I would categorize as not important and not urgent, because that person is already under treatment. The patient is already getting better than before, and the patient is just there for a reassurance. So this is how you classify, because like you might not just get a single case of a emergency. You will, when you get an ocular emergency, believe me, you will have like lots of people at the same time. When do the ocular emergencies come at to you at like a large number, especially when you have road traffic accidents. A bus falls from the the hills, or there's an accident, so there are 40-50 people there. Then what happens? Along with their facial and head trauma, they have, when a person has a face trauma, very likely they will also have some sort of an ocular trauma. So even when you are looking at 40 patients, then you have to learn. You just make a table like this into 4 different people. Then you say which is the most urgent and important, which is important but not urgent, which is urgent but not important, and which is not important and not urgent, right? So this is already, these are just some of the things you can find from the ocular history. I'm not going to read from the slides because it'll be there. It's more important for you to understand the whole the concept of the ocular emergency and how you have to deal with all these emergencies. So a small, like for example, why is a previous injury, vision, or ocular surgery important? Because a person who is playing, for example, let's say a person who has come to you and said, sir, I have a pain in my eye, there was some bleeding, and I had a hit in my eye with a tennis ball while I was playing tennis. Now, if that person has not gone under any surgery before, you might not worry very much. But if that was your patient whom you had performed cataract surgery, or if you have done retinal detachment surgery just few months back, then you would be really worried, because the intraocular lens could have come out from the wound site, the intraocular lens could have dropped into the vitreous, or if it's a patient who had undergone the retinal detachment surgery and he was fine, then you remove the silicone oil, and the same person now has a trauma, you would be worried a little bit more among that patient group. So again, it's all of these things, tend to give you the overall image, or the overall information about how emergency the case is. So this is a very important part in taking the patient's ocular history. So when you're looking at the patients, attending the patients with ocular emergencies, the rule number 1 is you do not do more harm. That is, as I mentioned, a patient might be having an open globe injury with the anterior chamber still fine, and the lens and the cornea still okay, and you do a USG and you start taking out the aqueous, the lens, and you make the anterior chamber flat when there's a vitreous loss with iris prolapse. So that's what you should not do. That's rule number 1. Do no harm. Again, as I mentioned already, the foreign body in the eye, don't do an MRI, because you might turn the ocular injury into a brain injury. So these are the things you must know when you're attending any case with an ocular trauma. So these are all of the other things that you have to ask: systemic conditions, medications. Is the patient already in under various medication? Because there are so many emergencies that we are going to talk from the next slide, that if there is some allergy to some medications, that patient might actually become worse, and those have to be kept in mind. So this is an overall layout of the emergency kit. So there can be a lot of other things that can be included, but these are the minimum. I'm just saying this is not exactly this. So these are the minimum things that you will require in your ocular emergency kit, because the best way to handle any ocular emergency is to be prepared for it. So you need a torchlight, a fluorescent strip, an eye shield, a few bottles of ringer lactate, atropine, tropicamide, few swabs, and povidone iodine, basically known as betadine, gauze, 27 gauge syringes or needles, some eye gauzes, some glass rods, litmus paper, and eye speculum. So these are the basic. These must be there. You can add more to it. It doesn't matter, but these are the basic. These things must be there you can create an emergency kit, and these things must be present there before you can actually start examining the patient, because the patient might be being kept in an emergency ward, and you might have to first go to the emergency and see the patient, and maybe later on the patient you can move to the ophthalmo department and do the examination. So if you do not carry all of this, just going there and looking at the patient at the bedside and just making a note, it will make no sense. So this is the suggested triage categories. You have to understand, so which is the most dangerous and which needs to be addressed immediately and which you can wait for some time. So this is a triage one. Triage one are immediate life-threatening conditions. Okay. So as I was saying, these patients, these need urgent, not the eye, but these need urgent other medical attention to save their life and not just the eye. Then you have the Triage 2, which is actually where the true ocular emergency starts. So these are basically the chemical burns, which are the acid or the alkali, the penetrating eye injury, which are the open globe injuries, and things which include sudden vision loss, which are mainly the central retinal artery occlusions, or severe eye pain, which could be due to acute glaucoma or post-op surgical, like endophthalmitis or corneal ulcers. So how we should proceed is, this is the Triage 1, the trauma with the chemical injuries, and these need immediate attention. If you receive a call or somebody saying, there's a history of like you're playing with a battery or something happened and you had an acid injury in the eye, you have to request the person that they immediately start putting water and start washing their eye immediately, because what happens is the acid, it quickly denatures the protein, causes them to coagulate. But like, this is helpful in a way that it does not prevent further damage from happening, but due to the coagulation, this is the end result. The cornea, they become scarred, and then bad, like a very terrible opacity starts forming. So that's another major problem. The other thing is the alkali. They are very, very notorious because like they cause saponification. They are slow to act, but they act for a very, very long time. For example, a case of Lyme injuries in children, the particles of the lime, they can sometimes get stuck in the upper eyelid, and what can happen is that thing slowly starts releasing the chemicals in a sustained release mode, and before you even know, you can have a full thickness perforation of the globe from the sclera reaching up to the vitreous. So that is very, very important. So severity of the burn is basically depends upon the contact area of the surface. So if it's just in the cornea, or was it like dust, or was it mixed, and how concentrated the particle was it a little bit of lime, or was it a very, very strong lime? So what was the time, and what is the depth of penetration, the time of contact, and degree of limbal stem cell injury? So these are very, very important. The main thing for an emergency is, what is the contact surface area, what is the time, and what is the time of contact and concentration of the substance. These four are mainly important for the overall management of the eye in the ocular emergency. But the depth and the degree, these are for the long term, but these four you must consider for managing any ocular injury due to chemicals. So the immediate management is usually to do a normal you can wash the eye with a normal saline or ringer lactate, or even if you do not have that, you can put plain water. Then always don't forget, you always have to evert the upper lid, and you have to continue the irrigation for 5 to 10 minutes. And what you do is, after you irrigate, you get something called a litmus paper. Then you have to apply the litmus paper to the conjunctival tissue or to the mucosa to see if the pH has reached the neutrality. If it has not reached neutrality, if it's still showing alkali in case of alkali injury, or still acidic in case of acid injury, then you have to continue the irrigation process. So these are some of the images, and again, to conclude about the chemical injury, it's about the acid, very abrupt but limited. Alkali is slow, but it is sustained. The treatment is urgent irrigation. So you have to remember these 3 P's. The irrigation, or when you are putting water or ringer lactate in the eye, it has to be persistent. That means it has to be continuous. There should be no break, like you should continuous. Profuse, meaning it should be done in large quantity, and prolonged means just washing the eye in just for 1 minute or 2 minutes is not going to do the work. You'll have to do it for 30 minutes or 45 minutes, and litmus test will tell you when you have completed the irrigation process. So this is the main important thing in management of the chemical injury to the eye. The second part, which needs the second ocular emergency, which falls under Triage 2 and needs an immediate medical attention, is an acute angle closure. So I'm not going to go into very details of the acute angle closure, but for emergency management, what you have to do is you remember this stamp. So it means supine position. You lay flat with your face facing towards the roof. So what this does is because the lens has some weight, the weight of the lens, it pushes the lens a little bit into the vitreous, and this can hypothetically help in opening the angles which are closed. Then you start with timolol, or you can add, usually you get something in combination called Combigan, which is a mix of brimonidine, and there you have the acetazolamide and mannitol and pilocarpine, usually pilocarpine in the other eyes. But basically, this is how you manage a case of an acute angle closure. And once this is done, you have to monitor the IOP at least 30 minutes using Goldmann applanation and see if the IOP is decreasing or not. Usually in most of the cases, what happens is once you've started mannitol, the IOP usually decreases. But if the IOP is still high despite use of mannitol, you might even have to perform a paracentesis, but that needs to be done especially in an aseptic, like a condition. So you might have to consult with your senior or an ophthalmologist and take the patient to a sterile area before you do that. Now, coming to the open globe injuries, this is the most important type of the ocular emergency. And the picture over here, you can see there's a penetrating injury in the cornea with a prolapse of the iris tissue. So usually what you have to look for is, you can see the shape, it looks like a teardrop. So usually when you have a puncture and there's a part of an iris or something coming out, or that is trapped in the cornea, it produces a teardrop shaped pupil. Or you can have to look for protruding content or the foreign body in the eye. If this diagnosis is still not clear, you can do Siedel's test, right? Or you can do a CT imaging. Remember, this is a CT, and even here it is not mentioned you do an ultrasound, you do a CT, not an MRI. If the injury is due to such particle in the eye and you do an MRI, it will cause more damage. So how do you manage? You have to call an ophthalmologist or your senior. You must, right? Because like these injuries need surgical intervention, so you must call the ophthalmologist. So something, you must not do something that will increase the intraocular pressure. That is mainly by doing, forcing too much pressure in the eye, or some people, they might not know and apply a pressure bandage. That should not be done, and never do an ultrasound using an ultrasound probe. And to prevent against infection, you can prepare yourself with the intravitreal injections of vancomycin and ceftazidime, and at the same time, while to prevent the infection from occurring, you can also start the patient on IV antibiotics, mainly with the vanco and ceftazidime. At the same time, when you're preparing to give the IV antibiotics, you can also prepare from the same contents in a syringe of the same antibiotics to give it in the intravitreal region. So you see, when you put an eye shield, you should not put a rigid eye shield which puts pressure on the globe. Many consider putting, something like, when you go at a coffee store and sometimes they put a coffee in a small, what do you call it? A small tray or small cup. Usually it's the size of the cup is like a small ice cream cup. So usually you put it in the eye and you just put a tape around it, because you don't want the pressure to be exerting on the eye. So there again, in the avoid using tonometry, avoid anything that will manipulate the eye, and avoid topical eye solutions. The only eye solution that you can actually use is topical moxifloxacin. It is a preservative-free antibiotic. All of the other antibiotics or eye drops contain preservative, most of them. So in an open globe, never use a preservative and any eye drops with preservatives, because the preservatives will cause ocular damage. And don't use if the patient needs repair under anesthesia. This is not required for you, but usually when they are done, needs to be under anesthesia, you do not put succinylcholine. It's one of the general anesthesia. If you put succinylcholine, what happens is it increases the intraocular pressure, and the wound tends to open up and throw everything from the intraocular content to the outside environment. The other part which needs to be immediately attended are the corneal ulcers. So I do not need to tell you much more about it, the corneal ulcers. Usually the corneal ulcers, they are already diagnosed under treatment, or they could be a new corneal ulcer. So what you just do is put them on a slit lamp, do a little bit of scraping if the lab does the culture, and do a fluorescence strip, measure the size of the ulcer, and start him with the 6A. The 6A is the first A is antibiotics. You can start with any of the antibiotics. It can be fluoroquinolones, or you can start putting the gentamicin or vancomycin or even ceftazidime topically. The other A is to check if the patient needs admission in the hospital. The other A is analgesics. The pain is very, very high, so you have to give the patient some analgesics to relieve the pain. The other A is anti-glaucoma. So you have to start them with ACE inhibitors. Mainly acetazolamide works perfectly in such cases. The other A is atropine, which helps in mydriasis, preventing the posterior synecdoche, also helps in regulating the internal humoral immunity in the eye, causing the ulcer to heal quickly. And the last A is antioxidants, or vitamin A or vitamin C, which can also help in early resolution of the corneal ulcers. And this is another emergency which you might encounter. That's a post-operative endophthalmitis. There is not much you can do. What you have to do is you urgently call an ophthalmologist, so the surgeon who has done the surgery. Then you contact all the patients who had undergone surgery on the same day or after the after the day in which this patient with endophthalmitis presented to you on, because you have to rule out that there is no such problems among other patients as well who were operated by the same surgeon in the same OT on the same day. So that needs to be ruled out, because they're usually, if it's an endophthalmitis due to hospital costs, due to properly unsterilized instruments, or due to a contaminated ringer lactate or balanced salt solution, it will happen in clusters. It will not just involve one person or one patient. It will involve all the patients. So you have to contact all the patients and make sure that they are all right. And in cases of sudden painless loss of vision, such as central retinal artery occlusion, although it falls into an ocular emergency triage 2, that means you have to attend the patient within 10 minutes. There's not much you can do about this patient, but you have to understand this, that most of the patients who come to you with central retinal artery occlusion, they have very, very high, it's usually due to hypertension, or they might have a embolic phenomena in the body. So you have to send them to a general physician to rule out what is the cause, because although this eye we might not be able to do much in this eye, the other eye needs protection. And at the same time, if the pressure is high and there is a source of emboli over here, what can happen is that these patients can have same problem in the brain, the heart, the other vessels, or the kidney. So these patients, if we just say they are central retinal artery occlusion and we just send them to other, like saying we can't do much, you can go home, they might actually die, because they might have stroke or a MI if their pressure is very high and central retinal artery occlusion was caused due to high blood pressure or some embolus in their body. So that is very, very important. Now we come into triage category 3, where you have to see the patient within 30 minutes after they arrive. So as you can see in the picture, it's not very severe, but it's not very simple as well. So usually these patients come with complaint of loss of vision, which is often painless, but not an artery, or mainly a vein occlusion, and which indicate a penetrating eye injury, which we are not very sure of an penetrating eye injury, but it could be a penetrating eye injury with a patient with a hypopyon, which could be due to various other reasons or due to hyphema. So to go back to this slide, I just wanted to show you these two sure signs of a penetrating, because sometimes it's very difficult to be not very sure that there is an open globe injury. So even via an torchlight examination, to find out that you have a sure sign of an open globe injury, what happens is if you see iris coming out, then you know that there is an injury, because without an injury that is full thickness, the iris will not be coming out. Or you see something that is going inside and is also present in the anterior chamber, because until and unless there is open globe injuries, you do not see the foreign body in the anterior chamber. So these are the two sure signs of open globe injury. One is the internal tissue coming out because there is a wound, because without the wound it won't be able to come out. The other thing is something going inside. If a foreign body is in the anterior chamber, there has to be a wound from where the foreign body entered the eye. So these can also be just, this does not require any special, slit lamp or anything. You can just find them out using a torchlight examination. Now going into the Triage 3, we already talked about the history of painless, like central retinal vein occlusion. Again, it's the same thing as central retinal artery occlusion, because these patients also tend to have high blood pressure or embolus, so these need to be ruled out. They send them to a physician, because our only job is to save the patient and save the other eye. Now, if the patient has a penetrating eye injury, we already discussed about this. If this is what you see, it's a sure sign of penetrating eye injury. And if you do a CIDL and you see a positive CIDL test, then you also find out that there's a open globe injury. So these categories are mainly for, if there is a foreign body in the cornea, superficial, and there is a case of a hyphema. So for superficial corneal foreign bodies, we all know how we can remove it. We just put a proparacaine or a local anesthetics. Then we just keep the patient on a slit lamp, and using a 27 or a 26 or a 27 gauge needle, we slowly pick the foreign body from the cornea from its surface. If you're not very sure if you're able to do it, or if you think you might cause an injury to the eye, don't do it here by yourself. Call a senior or a more experienced person, to actually help you with the process. And as for the hyphema, it can occur due to various reasons. It could be due to trauma, or mainly most of the time trauma. So the patient will usually come with decreased vision, photophobia, pain, and absence red reflex. You being like if there is no if the operating theater is not available, or if an ophthalmologist is not there, you can advise the patient to elevate the head bed 30 to 45 degrees. If the patient is taking aspirin or warfarin, you might need to stop those, but that needs consultation with the cardiac doctors, especially in sickle cell patients. Even in our country, in the Tarai belt, we have a lot of people, usually the people of Tharu community who have the sickle cell. So if such patient developed hyphema, do not use acetazolamide, because it can cause sickle cell crisis, and an ophthalmology consultation. And that consultation needs to be very, very urgent, because if there is a total hyphema, if there is an 8-ball hyphema, if there is an increased intraocular pressure, or the hyphema is recurrent, this patient might have come earlier with resolving hyphema, and again the patient has a hyphema again. So those category of patients, and those patients which you think there is a trauma and hyphema and also involvement of the posterior segment of the eye, you have to seek opinion or advice with a more experienced senior or your colleague, or consult with an ophthalmologist. So the triage 4 is usually the less, worrisome. You can see them within 60 minutes, and usually includes the flash burn. Usually they come at night, and it's also known as the welder's eye. Not much to do, just prescribe them with tear supplements, put a tropicamide and some, just that you just have to reassure the patients that they will do well. And in cases of flashes, small hyphema, which is automatically resolving, you can again do the same thing, elevate the head, put atropine in the eye. If the IOP is a little bit high, increased IOP over here means more than 31, but like if IOP is around 31, 32, you can prescribe them with timolol. And for flashes and hyphema, what you have to do is you have to know the anatomy of the eye. The flashes and floaters, they can be occurring from anywhere from the anterior chamber till the optic nerve. So here, if you have a uveitis, some cells going around, you have floaters, there was a trauma, and if the person had a trauma, then there was floaters, then that means they could have a vitreous hemorrhage or the vitreous degeneration, and vitreous degeneration could be presenting as a floater. Or worse, they could be having a retinal detachment, and the pigments from the retina could be floating in the vitreous, causing both flashes and floaters. So flashes and floaters, they would require a thorough examination, right? And if it's just a vitreous hemorrhage, you can wait and watch if it's very small. If it's just a uveitis, just prescribe them with antibiotics and the steroids and dilating drops, and you can just review again. But if you see that there is a retinal detachment or the patient needs some immediate intervention, then you might have to again seek help from your more experienced senior or from an ophthalmologist. Now, the category 5, they are the patients who often come to you at the ER and usually cause the trouble most of the time. Because these people are not the very important and not the urgent kind of cases. They usually come with conjunctivitis, blepharitis, chalazion, dry eyes, long-term history of floaters or subtarsal foreign bodies, so without any redness. So these patients can, for example, if you do not have any patient, you receive a call from an emergency and they tell you that a patient is having this, you will have to see the patient immediately. But I'm talking about if you are not able to, for example, you are somewhere and you need to consult the patient, you might think these patients need not actually be seen by you and they can be consulted over the phone, except for few categories such as the subtarsal foreign bodies, which will actually require you to invert the lid and wash. But since it's a lid, and if the other people who are in the emergency, they are also very, very, you don't need to be an ophthalmologist or eye personnel to remove a subtarsal foreign bodies, because I've seen people, around inverting the lid, taking a cotton or a handkerchief and removing the subtarsal foreign body more effectively than most of us. So then these are some of the examples of the category 5. You see a small tarsal, subtarsal foreign body, which can you just remove it by simply inverting and using a small cotton bud, and cases of chalazions or conjunctivitis, which can be dealt on later or just be consulted over the telephone if you are not able to attend the patient. So again, documentation is very, very important. It basically wraps up all of the information as said till now, because what happens is what the patient came for and what you did, it will all be present in a form of a documentation. Now, this patient will come in a follow-up and they will see whoever is seeing. If it's you again who's seeing the patient, then it becomes easy. But in case you don't get to see the same patient and somebody else see the patient, then that person who is seeing the patient needs to know a very, very clear history or the clear information regarding what had happened and how the patient was treated, and is the patient actually getting better or getting worse, right? So that is also the important thing, because you manage the patient, send the patient home, the patient comes back. The main thing is you can have is the 3 things. The patient could be feeling the same, the patient could be improving, or the patient could be getting worse. So to know this, you cannot know just by looking at the patient right now. You have to look at the patient, you have to know how the patient was before. So that will give you an idea if the patient is feeling better or actually getting worse. So this is basically a small log, red eye algorithm defining the conjunctivitis, iritis, acute glaucoma, and keratitis. I think you all are very familiar with this, and I don't need to go through it very much. In conjunctivitis, discharge is more. Iritis, we have the photophobia, and the pupil. Pupil is smaller or it's same, and photophobia is more marked. And in case of an acute glaucoma, what happens is you have a I think we have interference from one of the mics. All right, so I'll just continue. And in case of a glaucoma, you won't have a discharge, you don't have photophobia, more of a pain and a pupil which is large, oval, and fixed. While in a patient who has keratitis, the discharge and photophobia is slight, the pain is more marked, and the visual acuity, it can differ according to the site, and pupil may be small or same or smaller because of the blepharospasm. So to conclude our presentation, what I would like to say.
Basanta sir, can you please mute your phone? Basanta Paul sir, can you please mute your phone? Hello, Basanta sir.
Ocular Emergencies.
Basanta sir, can you please mute? Let me check. Please wait for a while, sir. I'm checking.
So to conclude the presentation, I would like just to say that to be able to handle any of the ocular emergencies, the first thing you have to be is you have to be prepared, and you have to know when to act timely. So we have discussed about the eye conditions which need the urgent, the important eye conditions which need an urgent attention, and also we discussed about some of the the kits or the equipments that are required as an emergency kit for you to be actually go and help the patient, because even if you know the triage very well, you know what to do, but if you're not prepared with all of this, you might not be of much help. For example, if you don't have a litmus, or you don't have a ringer lactate, or you don't have a swab, or you don't have a touchlight, and a person comes to you with acid or an alkali injury, although you know what to do, then you are not very well prepared to do it. So be prepared to act timely. Then the another thing is you have to classify the patient by risk of death over risk of sight loss. So if the patient is more likely to die than more likely to lose sight, then you have to just leave the patient, say okay, do whatever that is needed so that the patient can be saved, and we can do whatever needs to be done later. At that time, what you can also do is, if the person also has an open globe injury and also a trauma to the brain, then you can tell the neurosurgeon who is taking the patient into the surgery, saying that after he finishes the neurosurgery, he can call us, then we can do some of the repairs in the eye itself, so that the patient just needs to go into a general anesthesia in a single, just a single time general anesthesia for the patient. So the patient does not need to go under this harmful chemicals over and over again. And the other thing is, always remember, AID. A is ask for help when you don't know it. When you are very confident, you can intervene, but D, do no further harm. And always seek help when you're not confident. People will always help you, but don't just do things randomly. And in the end, document everything that you have done properly and plan appropriate follow-ups. Because, like, for example, what do you mean by plan appropriate follow-up? A patient who has an acute angle closure, call him within 2 or 3 days. A person who has a hyphema, call him in 7 days, because until 7 days you won't know whether the hyphema has decreased or not. Just looking the patient tomorrow, it's not going to say anything about whether the patient has improved or not. A person with corneal ulcer, don't call him at 1 month. You need, after starting the medications, you need to see the patient right away, maybe tomorrow or day after tomorrow, to see if the patient is getting better or getting worse. So that means you have to document the cases properly and plan the follow-up appropriately as well. So with this, I'm concluding my presentation. I'm finishing my presentation. This is the last slide. So if any of you have any questions regarding any of the conditions or any of the slides, you can please feel free to ask me. And with this being said, I would like to hand over the mic to Kapil. Yeah, thanks, Kapil.
Yeah, thank you so much, sir, for this presentation. If anybody have the question, please ask on a chat box, or you can unmute yourself and ask the question. So there is another question from the WhatsApp user. Sir, why not do MRI in a foreign metal body?
Okay, thank you. That's a very nice question. What happens is, for this to know, you have to know how the MRI works. The MRI works by using ferromagnetic substances. It creates an electromagnetic field around to create the images. So in that electromagnetic field, if you apply a little bit of, even if you apply a little bit of a, if you introduce something, small foreign body item, or even a small metallic pin, what happens is it tends to throw away the metal particles all around, because the magnetic force is so strong. And if it's inside the body, the magnetic force is so strong that it will even try to pull it out from the inside the body to the outside. So basically, when you have patients who have broken legs and have implants, or in the eye where you have a foreign body, or a patient who have gone under dental or maxillofacial trauma, and you have the metallic stents, or even patient who have a heart electronic heart pacemakers, they should not be they should not be sent for an MRI. For more information what an MRI does to the any foreign body, you can just Google and see for yourself how the magnetic field causes damage. Causes the metal objects to actually become active and cause more damage. I hope that answers the question.
Yes, sir. So there is another question from the Gauri sir. Thank you so much, Gauri sir, for your question. He asking for what are the things you recommend minimally for the primary eye care center?
Yeah. So this actually is this slide that I'm showing is actually for a primary eye care center, because this is very basic, because usually you can have a torch, then you can have an eye speculum, and usually you get the fluorescent strips and the litmus paper in a book, in a small booklet. Usually one booklet has around 25 to 40 strips, so you can just keep them. And you need to have a small syringe and the needle, some of the eye shields, and mainly the atropine, tropicamide, some swabs, and betadine. These are the I would consider this to be the minimal of the minimal things that would be required for anyone to at least address the ocular emergency that you might face in your daily practice.
Okay, sir. So there is another question from the Amit Kumar Singh, sir. He is asking for his question is, some say to put atropine, or some say not to put in the case of OGI, but you say no need to put the drops beside mosifloxacin because of preservative-free in nature. What to do? Please elaborate.
Okay, so Thank you, Amit, for your question. I would suggest not to put anything besides moxifloxacin in the eye, because atropine is an atropine sulfate, which contains the preservative BAK, that's benzyl alkoxim. And what you actually do is, when you put an atropine in an eye which has open globe injury, you actually dilate the pupil. And when you dilate the pupil and you have a wound in front in the cornea which is open, you are actually opening the window or opening the gate. The iris is acting like a diaphragm, preventing the lens from coming forward. And because the vitreous is pushing the lens forward, and while the iris is while the pupil is constricted, the iris does not let the internal content come out. So when you dilate it, the first thing is you're opening the gate for everything to come out. And second, the most important thing is the atropine contains the preservative chemicals, which would actually cause damage to the ocular tissues, because all these preservatives are very, very dangerous and toxic to the iris, to the ciliary body, and to the retinal tissue. So it is only recommended that you use only moxifloxacin. I have never read or come into practice where they say put atropine in a case of an open globe injury. It could be true in a closed globe injuries, but in open globe injuries, I would not recommend anyone to put moxifloxacin. Put anything except moxifloxacin.
Okay, so how to manage the CRAO?
So the management of CRO is very, very difficult. I thank Amit for the question, but I would like to elaborate furthermore that the case of a CRO, even if it's like in a running OPD, even if you have the latest things in your operating theater, even if you are very, very well prepared, what happens is this patient, by the time they have the symptoms and they come to us, the damage that is done is usually permanent, because like CRO, basically, if you do it, if anything that you do helps, you can only save the vision as long as it is done within 1 hour, because after 1 hour the permanent damage of the retina starts. It's like the damage on the retina is permanent. So as you have mentioned, there are various other ways which is thought to help patients in CRAA. Ocular massage is one of the case that, like, even with the I'm having some interference from other mics.
Okay, sir. So there is another question from the Chandan Mahato. Thank you so much, sir, for your question. Sir, what do you suggest for emergency management of lid laceration in case of RTA?
So in case of I will get to the question of CRAO by Amit again, because I wanted to say how the ocular massage help. But first, let me ask to answer the question by Chandan Mahato. So he has asked, like, what do you suggest for emergency management of lid lacerations in case of RTA? So these lid lacerations, first thing you will have to see is if the lid laceration has involved the lid margin, or has it also involved the punctum area. So usually the lid lacerations which has involved the lid margin and the punctum, I would suggest that you send the patient to you refer the patient to an ophthalmologist, and especially to an oculoplastic surgeon, because like you can repair the eye, you can repair the lid, but if you don't repair it properly, what happens is you end up with landing the patient with an ectropion or an entropion. So that will again cause a major problem, because now that problem, if a person comes with ectropion, entropion, even if you have managed for the considering good for the patient, then the patient will come to you saying now he has an entropion or ectropion, and that will be very, very difficult for the oculoplastic surgeon to be to correct it as well. So if it's not involving the lid margin or the punctum, if you have the technical skill, small wounds, like maybe you can apply sutures, but like if it's the margin or a full thickness lid laceration which has split the lid into two or involving the punctum, I would suggest you to, you know, like just put a bandage or apply the antibiotics and refer the patient immediately for further management.
Okay, sir. Thank you, sir. Sir, I guess I don't read full commercial questions. So can you please explain about the ocular massage in case of CRAO?
Yeah. So what happens is in CRAO, basically the mechanism of the ocular massage is that when you press the globe and you release it suddenly, you are just hoping. You're just hoping that whatever is obstructing the optic, the central retinal artery, it just gets dislodged and it goes to another place. But even after repeated, you know, like ocular massages, the chance of success is very, very low. So, but like nevertheless, because you know, you don't have much to do in those such patients. If the patient has arrived to you within 1 hour saying that, and you feel it's in central retinal artery occlusion, what you can do is you can try the ocular massage for around 10 minutes. You can try it. There's no harm. But if that person has already a history of central retinal artery occlusion for like 1 or 2 days, then number one, ocular massage does not help. And even if it helps, the retina is already damaged. So even if it gets dislodged, the vision won't be there. And the more important than the ocular massage is find out what caused the central artery occlusion, whether it was the high blood pressure or was it something which is more dangerous, because like that eye could be gone. Your main aim will be to protect the other eye, at the same time also protect the person from having a heart attack or a stroke. So that will be your main goal.
Okay, sir. So, I have also thought about the gonococcal conjunctivitis is one of the cause of emergency condition. So, if you have to explain about it's related with the emergency or how it's emergent condition to manage the gonococcal.
Sorry, which conjunctivitis? I didn't get it.
Gonococcal conjunctivitis, sir. Yes, sir. What is about the gonococcal?
Okay, yeah.
Yes.
So gonococcal, yes, thanks. So if, like, again, you know, usually when you have a conjunctivitis and the patient gives you a history of gonococcal, mainly it's like a mucopurulent. That's what I'm saying. You know, like all of these emergencies is the main thing is, even if I've said if you can attend the patient in 30 minutes, 60 minutes, it doesn't mean that, for example, if I'm in the duty, I do not have any call and I get a call saying there's a patient with conjunctivitis, can you see? I do not say that patient can be seen after 60 minutes. I will come later on. If I am free, I have to go and see the patient immediately. The concept of triaging which patient to see first to preserve the vision is when you have lots of patients, and that's in that case. For example, if I have an open globe injury and a patient with chemical injury and a patient with gonococcal conjunctivitis, still I would look at that patient in the last, even if it's an ocular emergency, because it's important but it's not urgent. So I hope that answers the question of the emergency. But when you have a patient with like a gonococcal, if you're suspecting such patients, I think the best thing for such patient would not to be just prescribing antibiotics and sending them home. They need admission. If it's a child who has a gonococcal you know, conjunctivitis, mainly in the ophthalmia neonatorum, his mother and the child both need to be treated. If it's an adult who has a gonococcal you know, infection, then that person's contact history, because we all know gonococcal is mainly transmitted via sexual contact, so that his partner or her partner must also be identified and treated by admitting them in the hospital.
Okay, thank you, sir. So there is another question. So how to decide to apply hot and cold compression? Thank you, Umesh, sir, for your question. Yes, sir.
Okay. So thanks, Umesh, for the question. I would just like to highlight a few things, and this is actually from the recommendations from the European and the American Academy of Ophthalmology. There is usually, just remember one thing, there is no condition in the eye besides only two conditions that will need not hot but warm compression in the eye. Just two conditions. The one is meibomian gland dysfunction. The other one is chalazion. Besides those two things, there is nothing for which we'll apply a warm compression. And for cold compression, I would suggest do not apply it for, you can apply cold compression, it does not do much damage, but please do not apply it for any eyes which you think is infected. It can be applied in trauma or simple swelling or other things, but don't apply it in an infective. Why I'm saying this is, although it helps in improving the condition a little bit in the eye of the patient, what the warm compression will do is, usually it's done with an ice wrapped around a towel. When you put it over the ice melts, then those liquids from the ice, it starts dropping everywhere. The towel is contaminated, and actually, although you are getting relieved, you are actually increasing the chance that the infection will spread to other people. So I hope that answers your question. It's not hot, it's warm compression. Warm compression is only for meibomian gland dysfunction and for chalazion. There are no other indications for applying a warm compression in the eye besides these two pathologies.
Okay. So I guess we have answered many of the queries. If anybody have queries, please you can unmute your mic and you can proceed with the question. Okay. Thank you so much, ANADI, for this wonderful presentation.
Yeah, thank you.
I guess we have answered. Yeah.
I guess it was helpful for all of you.
Yes, it definitely was. So before ending the session, I'd like to again express my sincere gratitude towards the presenter, Dr. ANADI, and all the attendees and also I'd like to appreciate all the helping hands for the iTalks program. Herewith, I'm ending today's session, requesting all you please drop your review and feedback for us. Stay safe and keep in touch. Thank you so much. Thank you so much, ANADI, sir.
Thank you, Kapil. Great job. Continue your great work. And if you need any further help from me, please let me know. I would be very, very happy to help you. And thank you for all the participants of this for attending this webinar. Thank you.
My pleasure, sir. Thank you so much. Have a good day, sir.
Yeah, you too. Have a good day and stay safe, everyone.